Спасибо. Good afternoon, my dear student. Today the topic very important because it can affect anyone of any age, but will in the period of puberty. But before we talk about acne, we must talk about sebaceous gland. It has an important role in the development of disease. Sebaceous gland are exocrine glands that release sebum. These glands are connected with the hair follicle, and in the most cases, sebum in released through the same pore through which hair grows. Sebaceous glands are located on very surface on your skin, the exception of your palm, bottom lip, and the sole of your feet. In the average adult up to 20 grams sebum is secreted per day. Between 400 to 900 sebaceous glands in 1 square centimeter are located in seborrheic area. Maximum activity of sebaceous gland in a healthy person begins at puberty and lasts up to 24-25 years. Varied density of sebaceous gland distribution. Scalp, face, 400-900 in 1 square centimeter. Upper part of third, chest and back, 300 and 500 square centimeter. Extremities, 1500 in 1 square centimeters. Sebaceous gland function by producing and releasing sebum in order to help protect and lubricate the surface of the skin. Sebum is composed of fat, cellular debris, and keratin. Sebaceous gland composition: triglyceride, wax ester, fatty acid, squalene, diglyceride, cholesterol ester, and cholesterol. Sebaceous gland function: soften epidermis, give it waterproofing properties, regulate water evaporation, block penetration of certain substance from the environment, impart antifungal and antibacterial effect. Sebaceous gland regulation: androgen increase sebum production and estrogen reduce it. The embryologic development of the human sebaceous gland is closely related to the differentiation of the hair follicle and the epidermis. The number of sebaceous glands remain approximately the same throughout life, whereas their size tends to increase with age. The activity of sebaceous gland increases during puberty because of heightened levels of androgens. Androgens are well known for the effect on sebum excretion, whereas terminal sebocyte differentiated is associated by proximal proliferator activated receptor ligands. The sebaceous gland regulation: the gland skin sebocyte contain an enzyme called 5-alpha reductase, which converts less potent testosterone into more potent dihydrotestosterone, which is directly responsible for sebaceous gland activity. That stimulates the sebaceous gland, causing an increase in sebum production, which can lead to an oily skin or involved in skin problems such as acne. Acne vulgaris. Acne mean eruption and vulgaris mean common. Acne is one of the commonest skin disorders, if not the commonest. It has been estimated that 70% of the population have some clinically evident acne at some stage during adolescence. Acne vulgaris is chronic disorders of the pilosebaceous apparatus caused by abnormal desquamation of follicular epithelium, leading to obstruction of the pilosebaceous canal, resulting in inflammation and subsequent formation of papules, pustules, nodules, comedones, and scarring, with varying extent and severity. Well, the course of acne may be self-limiting. The sequelae can be lifelong, with beaded or hypertrophic scar formation. Etiology of acne, genetic factor. If both persons suffer for such disease, likelihood of its development in children is 15%. The number, size, and sensitivity of receptor of the sebaceous gland is genetically determined. Hormone disorders, absolute hyperandrogenism, relative hyperandrogenism, elevated activity of 5-alpha reductase. Androgenic hyperandrogenism, antibiotic steroid, androgens, progestin intact. The effect of stress, pathology of immune system, gastrointestinal disease. Acne pathophysiology. Four mechanism of acne pathophysiology. Androgens stimulate sebum production and proliferation of keratinocytes in hair follicle. Shades of desquamation keratin obstruct the follicle opening, which forms the procalcitoacne. The result in sebum accumulation and swelling of the follicle. Bacterium colonize and proliferate in the blood follicle. This causes the hydrolyzation of the sebum triglyceride into free fatty acid. This further blocks the follicle, and pro-inflammatory mediators cause inflammation of the follicle and surrounding dermis. Follicular hyperkeratosis. Changes in follicular keratinization in the lower portion of the follicle invendibilium. The normal process of keratinization occurs in the same way that it occurs in the skin surface. This maturing of keratinocytes and subsequent exfoliation into the follicle make the beginning of the formation of comedones. In acne patients, these keratinocytes tend to stick together because of the effect of positive and negative charge, the action of transglutaminase, and the thickness of sebum. The clumped keratinocytes block hair follicle or ball or orifice of hair follicula, creating to blackhead. If the pore is open comedones, or whitehead if it's closed comedones. The closed pore is create natural source for bacteria, so Parenobacterium acne gravitate to the blood pores. The immune system recognize the presence of bacteria and mount an immune responsible, resulting in redness, pus, as well as inflammation and the topical virus type of skin rashes, pimples result. Most of the inflammation, however, is likely due to inflammatory mediators that are released when bacteria digest sebum. Sebaceous gland hyperactivity. In increased sebum secretion, sebum gland activity, the imbalance between sebum production and sebum and the secretion of capacity lead to blockage of the sebum in the hair follicle, followed by inflammation. Occlusion of follicle canal. Follicle hyperkeratin, abnormal follicular keratinization, keratinocyte cohocylins, and proliferation. Pilosebaceous orbis in acne is occluded by keratinous plaque induced by chemical present as ingredient of cosmetic. Microbial colonization. The bacterium, Parinobacterium acne is considered by key player in acne development. Studies have shown that Parinobacterium acne use sebum as source of energy, and it is present in the pore initial and immune responsible that target inflammation. Parinobacterium acne in sebum gram positive and anaerobic route, resident flora. It is resident flora in follicle, but acne patient with high concentration. However, Parinobacterium acne is highly abounded in the pores of individuals with and without acne, which indicates that is not simply the presence of this bacterium that drives the skin condition. Releasing of inflammatory mediators, distant follicle ruptures, releasing inflammatory chemicals into the dermis, stimulating intense inflammation. Ductal epithelium also produces cytokines and triggering an inflammatory cascade. Microbes as produce extracellular enzyme which attracted inflammatory cells. Acne localization. The greatest number of sebaceous gland follicles are located on the face, chest, neck, and upper part. These are the areas of acne localization. Clinical manifestation. Individual lesions are centered on the pilosebaceous until the hair follicle and its associated oil gland. Superficial lesion, open and closed comedones, blackhead or and whiteheads, bubble pustules, deeper lesion, nodules, large painful red skin rashes, pseudocyst, cyst-like fluctuant swellings, secondary lesion or post-acne, excoriation, erythematous molecules, pigmented molecules, scar or virus type. What is comedones? What are comedones? Comedones are non-inflammatory elements resulting from plaque of the mouth of the hair follicle. Closed comedones or open comedone. Submarine comedones respond poorly to medical treatment, and after long used ointment, corticosteroid ointment. Clinical history: acne comedones, acne comedonica, acne babulosa, and acne pustulosa. Yes, present papula pustulosa together, acne papula pustulosa, acne indurata, acne indurativa, acne flagminosa, acne ganglopata, acne fulminans, also known as acute febrile ulcerative acne, acne universa or hidradenitis suppurativa. The American Academy of Dermatology classification scheme for acne denotes the following three levels. Mild acne, characterized by the presence of comedones, non-inflammatory lesion, few bubbles and pustules, generally 10 to 10, but no nodules. Moderate acne, presence of several to many bubbles and pustules along with Comedones 240. The presence on more than 40 bubbles and pustules, along with large, deeper nodal inflammatory region up to 5. Dones moderate severe acne. Severe acne presents of numerous of extensive bubble and pustule as well as more nodal lesions. Nodal cyst acne, not acne vulgaris, severe form of acne with nodal cyst acne. Inflammatory skin element, deep skin element, after resolution or after healing formation scar. Different type of scar. Acne comedonica formation, black head, opening comedone or white head, closed comedones or called submarine comedones after a long time intact corticosteroid ointment. دواء إبليس بس مطرب في
If we look very closely at the skin surface, we can see thousands of tiny openings called pores. These pores are the openings of follicles which are under the skin surface. Tiny glands continuously pump oil, also known as sebum, into the follicles. The oil travels up and onto the skin. The follicle is lined with cells which produce a material called keratin. This keratin joins the oil that is flowing through the follicle. Bacteria can also be found in the follicles. Every hour of every day, this mixture flows out of the pore openings as long as the pores remain open. Unfortunately, pores can become clogged and start the acne process. Creams or makeup may block them. But most importantly, the pores can become clogged by touching or rubbing with the hands. This can push dead skin cells down into the pore or cause a layer of skin to cover the pore. When pores are blocked, the oil and keratin that are being pumped into the follicle can't get out. Pressure builds up and makes the follicle expand like a balloon being filled with water. As the follicle gets larger and larger, this stretches the follicle walls. Tiny holes can form through which bacteria and other contents in the follicle can leak out. This attracts cells of inflammation, which try to fix the problem. The cells lining the canal start to produce more keratin to shield themselves from the increasing stretch. Unfortunately, this additional keratin adds even more material to the canal. As more and more oil and keratin build up, the follicle can actually burst, causing much more inflammation. This is the point where we see red bumps and pimples on the skin.
Both whiteheads and blackheads are comedones, which means a hair follicle with a plug made up of oil and dead skin cells that traps bacteria beneath. Microscopic glands in the skin supply an oily substance called sebum to hair follicles, often called pores. Sebum is designed to lubricate the hair and skin and usually drains to the surface. Sometimes, however, the sebum becomes blocked and bacteria begin to grow. If the buildup of sebum and bacteria does not have an opening to the surface of the skin, it is called a whitehead. A blackhead forms if the pore opens to the surface, allowing air to enter. Sebum contains a pigment called melanin, the same substance that gives our skin color. Melanin turns dark or oxidizes if it is exposed to the air, which is why blackheads are dark. They are not dirt, and scrubbing does not remove them. Both blackheads and whiteheads can release their contents and heal, although this process can be slow.
Severe form of acne. Acne indurata. Indurativa is characterized by the formation of deep infiltrates with the formation of a scar and is prone to marriage cystic cavities filled with pus. Phlegmonous type, indurativa and phlegmonous acne can called nodal cyst acne. Nodal cyst acne is a sign of fairly severe course of acne. Acne, acne excoriata. Excoriated acne, these are the acne that occur predominantly in the patient prone to excoriatum, even minor eruption. Thus, excoriation may be at the background of initially extending acne and without them. This clinical type may be associated with obsessive neurosis or indicate more severe psychotic pathology. Therefore, patients with excoriated acne should be advised to consult psychotherapist and neuropsychiatrist. Acne gangulata. Acne gangulata is nodal cyst element connecting with each other, as well as with large comedones. Lesions can be located everywhere. They are resolved into colloid. They relapse until the age of 40 and sometimes last even lifelong. Acne fulminant, also known as acute febrile ulcerative acne, is a rare severe type of acne. The disease occurs more frequently in men aged 13 to 18 years. With milk papulopustular, really nodal cyst type on acne, and is characterized by sudden onset appearance on necrotizing ulcerative element, mainly on the trunk, and general symptom of intoxication on the background of chronic severe disease, associated with fever, myalgia, and arthralgia. Acne universa. Acne universa is associated with secondary region of apocrine sweaty gland. Initially, there is occlusion of the hair follicle and apocrine sweaty gland are involved in the process again. The disease develops after puberty and is combined with high body mass, localization ampus, perineal region, navel areola. As a result, fistula are formed with the formation of inverted scar. The course is chronic with relapses. Post-acne. At resolution of inflammatory element, purple, pustules, and nodules, secondary changes in post-acne are formed on the skin of patients. These are the persistent changes on the skin resulting from a long-term acne and seborrhea, and manipulation performed to treat these diseases. Post-acne. Uneven skin texture, permanent scar, stangent spot, secondary hyperpigmentation, persistent erythema, dilatation of capillaries, hyper and hyperpigmentation, psychological problem, depression, anxiety, social isolation. The intensity of post-acne is associated with age and duration of exacerbation. Treatment. The choice of the treatment should be based on anamnesis, adequate clinical assessment of disease, assessment of psychosocial status of the patient with acne, psychosocial status of acne. Be sure to recommend daily cleansing of the skin. When caring for skin, one should avoid fatty creams and ointment causing hair follicle occlusion. Local hygiene, regular gentle cleansing, not overzealous with soap and water should be encouraged. Application of oil-based cosmetics should be avoided as they may be aggravate acne, but water-based cosmetic can be used. Diet, stress, acne-induced stress, and this need to be handled. Some patients with mild acne may be more distressed than those with severe acne. Stress itself may induce acne. The success of acne treatment is possible only if it affects all factors of pathogenesis. It increases sebum secretion, abnormal keratinization, Bacterium of colonization, and inflammation. Treatment is multi-pronged, attacking the four mechanisms which lead to acne. Principle of acne treatment: mild acne, topical retinoid. You can use topical retinoid, benzyl peroxide, azelaic acid. Usually present bubula pustula, topical retinoid, topical antibiotic, benzyl peroxide. Moderate acne, present bubula pustula, oral antibiotic, and topical retinoid plus benzyl peroxide. Yes, to present nodules, deep skin rashes, nodules, oral antibiotic plus topical retinoid plus benzyl peroxide. In yes, net effect, no, we can use oral retinoid. Severe form acne, nodule, nodular acanglabata acne, oral retinoid, oral antibiotic, topical retinoid plus benzyl peroxide. Benzyl peroxide mode of action is powerful antibacterial, decreasing population of Bacterium acne. Also has anti-inflammatory effect. Indication: mild acne is stand-alone therapy, especially if few inflammatory lesions also present. Always to antibiotic therapy to reduce resistance. Moderate severe acne as topical adjunct to systemic therapy used in the both inflammatory and non-inflammatory acne. Topical antibiotic. Most frequently used topical antibiotics are clindamycin and erythromycin. Mode of action: Parinobacterium acne and its mediators of inflammation and so are more effective against inflammatory acne. Clinical use: useful in inflammatory acne, but the must always be combined with topical retinoic acid or benzyl peroxide. Side effect: resistance of microorganisms to antibiotic is a major problem, so should be combined with topical retinoid or benzyl peroxide. Topical retinoid, commodolytic and work by normalizing follicular keratinization. Comedons are treated with topical tretinoin cream. What are the side effects? At the beginning of therapy, the acne may appear worse, but after 3 to 4 weeks, it improves. The side effects can appearance, photosensitivity, and skin irritation, which therefore requires protective clothing and sunscreen. Protective clothing and sunscreen. It should be avoided during pregnancy since there is a risk of birth defect. For those who cannot tolerate topical tretinoin, we can use peeling agents like salicylic acid and gluconic acid cream. We can use other cream but with few side effects such as skin irritation and photosensitivity. Adabaline and tazarotene both are effectively like tretinoin. Adabaline 1%, 1%, tazarotene and azelaic acid or skinnarine. Topical retinoid, tritium affected by ultraviolet light and oxide by benzyl peroxide. Therefore, it should only be applied at night and not used concomitantly with benzyl peroxide. System treatment: antibiotic. Drugs used: doxycycline and monocycline are most commonly used. Less frequently erythromycin and azithromycin. Mode of action: inhibit growth of Parinobacterium acne and its metabolism. Direct anti-inflammatory effect. Indication: moderate to severe acne, beginning the most frequently used systemic therapy. Mild acne, if if acne is affecting patients widely offline, severe acne if oral retinoid cannot be used. Acne if oral retinoid cannot be used. Severe degree of acne therapy. A combination of standard topical and general treatment is necessary to treat severe degree of acne. Severe inflammatory acne is when we can see more than 100 comedones or more than 5 cysts. Here it is not enough to use antibiotic or topical treatment. Here we have to use our strongest drug, namely oral isotretinoin, which is retinoid that is related to vitamin A. The therapy should be between 16 to and 20 weeks. Before beginning the therapy, we need to check some lab values of the patient like fasting, glucose, triglycerides, cholesterol, complete blood count, and liver function. Other side effects are redness, dryness, irritation, and peeling of the skin. The woman should not take this drug if they are pregnant because breast defect can happen to the baby because this is very serious. Pregnancy test should also be done before the beginning of the therapy and monthly and until 1 month of the of therapy stop. So the woman should use two methods of contraception for 1 month before the treatment, during the treatment, and for at least 1 month after the treatment. In women with severe manifestation of acne with the effectiveness of antibiotic therapy, combined oral contraceptives with estrogen profile or anti-androgenic drugs are administered after examination by gynecologist and endocrinologist. Isotretinoin is powerful medication used to treat severe inflammation acne. It is an oral medication that is taken once or daily. This medication is probably best known by the no defense brand name Akutam. Isotretinoin, not to be confused with tretinoin. It is classified as retinoid made for synthetic form of vitamin A. It is taken orally in pill from once or twice daily. It's considered the most effective prescription treatment available for severe acne. Isotretinoin can successfully treat and completely clear up acne, even acne that has not improved with other treatment. Method of cosmetic correction. Glazing of face, cosmetic anti-inflammatory treatment, cryotherapy, chemical peeling, phonophorese, phototherapy, Darsan valve laser therapy. Rosacea. Rosacea acne rose is a chronic relapsing disease, usually of facial skin, having polyetiological nature and characterized by phases of its course. Rosacea manifested itself primarily by arising hyperemia, redness of face, telangiectasia, dilatation of a small blood vessel on the face, as well as hyperplasia of the sebaceous gland and connective tissue. The basis of the disease, they are changed in the tone of the surface of the blood vessel of the skin, caused by the action of various external and internal factors. Rosacea is a very common disease among dermatological diagnoses. It is about 5% occurs in all races. Rosacea begins in the most cases at the third or fourth decade of life. Flourishes between 40 to 50 years. Often affects women. The disease should be called rosacea. Because rosacea, ده ما تقدرش. Rosacea etiology. Endogenous factor, genetic predisposition, presence of more large on or at superficial blood vessel on the face. Disruption of the digestive tract, gastritis, gastric ulcer, fasciculitis, gallbladder disease, neurovegetative and endocrine disorders, thyroid hormones imbalance, menopause, and hypertension. Exogenous factor, climate, eating habits, wrong clear, emotional entropia. Rosacea pathogenesis. Increased vesicular permeability of the skin, accumulation of mediators of inflammation and metabolic products, serotonin, bradykinin, prostaglandins, avoid peptides, and gastrin. Degeneration of dermis matrix and vesicular endothelial damage. Classification. Clinical classification based on the succession of stage. Rosacea diathesis is occasional hot flashes. Rosacea prober, erythematosus telangiectasia. Pustulopapular, present erythema, telangiectasia, papules pustule. Pustulonodular, persistent erythema, numerous telangiectasia, papules, pustules, and swelling nodules. Special form of rosacea, rosacea steroid, granulomatous, gram-negative, gangliopathy, fulminant, rosacea with solid persistent facial edema, ophthalmic rosacea, rhinophyma, and phyma of other localization. Rosacea probe is characterized by persistent erythema predominantly of the nose skin, usually with presence of telangiectasia with periodic rush of blood to the face as a result of endogenous, psychogenic, and external stimuli. The modex might thus are completely absent or detect as single sample on the skin. especially in the follicles on the nose. Antiparasitic treatment has no effect in this case. Rosacea complicated with demodicosis. In this form, beside the usual phenomena of rosacea, there are scattered microbubbles and follicular micropustules in which demodicites are found. At antiparasitic treatment, pustules and bubbles disappear but present erythema and telangiectasia remain. Rosacea-like form of demodicosis in which there is a large number of mites and which may resemble a rosacea provia, but it responds well to antiparasitic treatment. Ophthalmic rosacea, blepharitis, erythema, desquamation, and crust of the edges of the eyelids. Conjunctivitis, iritis, scleritis, keratitis are frequently symptoms of rosacea. The severity of the eye damage does not correspond to the severe of the scaling process. In severe case, it can lead to blindness. Hypertrophic rosacea, rhinophyma, gentophyma, metaphyma, otaphyma, liverophyma. It developed as consequence of tissue hyperplasia of sebaceous gland and subcutaneous fat and sebaceous gland. The skin thickness takes on lumpy appearance, remains orange pale. It is observed more frequently in men. Differential diagnosis with acne and folliculitis. Treatment: elimination of etiological and think factors, treatment of comorbidity, diet, antibiotics, synthetic retinoid, antihistamines, vitonic angioprotectors. Спасибо. Your attention. Selezione panciaria e via passare il 20 film. Oh, semplice. Не ту фильм поставил.
Не тот фильм вы
Да
поставили?
ладно, ничего страшного, уже все.
Хорошо, завершаем.
Да, завершается. Сколько там еще? Час?
Да, 10:43.